everybody. Welcome to the Black Medical Journal. I'm Dr. Quanita Crable, and I'm here today joined by Dr. Jill Waggoner and Dr. Tamika Perry. Dr. Perry, how you doing? Can you tell us a little bit about yourself?
I absolutely can. So my name is Dr. Tamika Perry. I am a family physician in the Dallas area for about 20 years. I love servicing the community, and I am HBCU strong.
All right. That's awesome.
Yeah.
Phenomenal. And Dr. Waggoner, can you explain and tell the audience about yourself?
I can. It's been
20 years, Dr. Waggoner.
Okay, I'm Dr. Jill Waggoner. I am a family practice concierge physician, and I've been practicing in the Dallas area for 30 plus years. I started when I was 2.
Of course. Yeah, we just love, Dr. Waggoner and I have been in the Oak Cliff area. We've been in the southern Dallas area for all of my career, pretty much all of your career too. And, when I first started, I was, Dr. Waggoner was my mentor. So she's still everything to me.
Yeah.
Let me tell you, this woman is phenomenal. So just in case you didn't know, she was a Dallas Cowboy cheerleader. She's been on episodes of The Love Boat. When I say, like all hats off. Like, sometimes I'm like, I should have did more with my life. But, she laid a pathway for many of us to really partner with the citizens of Dallas to provide equitable, equal healthcare in a manner that's conducive to the population that we serve.
Thank you so much. That's really sweet. I think it's real important. One of the reasons that I always like to make sure that I mentor younger physicians when they're coming in, I think that it's important to know as a Black physician, you guys know that already, as a Black female physician, we are not just doctors, we're everything to everybody. So you are helping, folk at the school figure out how to do the sports physicals, and you're at the church helping people who are, diabetic and all of the rest of that. So we do all of that stuff, and I think you guys know what that is. So having this conversation, I'm ready for it.
Yes, and it's so important where people, it's super important when the physician looks like the community, but also equally important if that physician doesn't look like the community, the physician can identify with the community, right? So, Dr. Waggoner probably will attest, and so will you, is that, your physicians will come in, or your patients will come in, and they will have applications for you to help them fill out because they feel that comfortable with you. Like, can you just tell me what this means? And I feel like as a person of color serving our community, that is part of our job. That is part of our job, to help and to disseminate information and to disseminate knowledge and to make that person feel comfortable because somebody helped us get to where we were at. Sure. And I don't know about you all, my parents definitely did a great job in fostering me to become a physician, but they were not physicians. I didn't come from a family of physicians, lawyers, accountants, any of that. So, definitely paying it forward is something that we all should be passionate about. And I think that we all are passionate about. And secondly, so y'all got to stop me because I'll just keep talking.
No.
Because, I like to talk, right? So maybe I should have been an attorney, but I like to talk. So secondly, I think it's important that the community can identify with who's providing health care to them in a way that is fair for them and that makes the community feel comfortable. So when someone comes to the office and they say, my kitchen is turning gray, I know they're not changing the color of their appliances.
Exactly.
Right?
Exactly.
I know that they're talking about the nape of their neck, the hair in the nape of their neck. And that's something that's innate, that, it's ingrained in our community. I mean, Doctor, you probably find the same thing in GYN, right?
Of course. In GYN, seeing patients, one conversation that Dr. Jill and I had before we started was that a lot of patients will come to me for a second opinion. And one of the big things that I see is I treat a lot of women with fibroids. So I'm an OBGYN, and I see myself as the fibroid doctor. And so a lot of young women will come to me and say, hey, I went to 6 other doctors and they told me I needed a hysterectomy. What's different about you, Dr. Crable? Why are you not saying that I need a hysterectomy? Well, I think the talent and the skill that has been placed on me has afforded me the opportunity and the possibility to remove the fibroids without doing the hysterectomy. And so just advocating for patients and patients advocating for themselves. So I just think that's important. And, Dr. Jill, kind of tell us what you see when it comes to that situation and advocating and patients looking like you and coming to you for your expertise because of who you are?
I really, we started having this conversation before while we were waiting on you to come, Dr.
My clock was with
No. The newer doctorate, I'm sure. But one of the things that happens, particularly when you have, there's so many resources, good or bad. So people get their information from a lot of places. And I think what happens, and we talked about this a little bit earlier, and I'm sure the same for you, Dr. Perry, is that patients will get their information. So now they come to you with this information, these preconceived notions about how to treat this and what to do because they saw somebody on TikTok or something.
Exactly.
And they've gone to other physicians that may not look like them, that may not have the same cultural sensitivities that they do. And now they don't know what to do. And so you are saying to them, well, let's try this treatment or let's try this treatment. And I was telling you, as a physician, I always try to integrate healthcare and treatment. So what I will say to them, well, what did Dr. Crable say? She says, I need to have some surgery. I don't want to have any surgery. And I'm saying, well, let's do this. What's wrong with doing surgery and changing your diet? Why don't you do both? Why don't you, if you want to go vegan or whatever, why don't you do that and surgery? And I think that particularly in our community, that is necessary for us to have sensitivity to that and not just poo-poo them and think they're crazy because they want something different, because there's always the trust factor.
always.
Somebody wants to take out my uterus. So now what?
And the trust factor is very real, and rightfully so. I mean, we can sit here and cite instances in history.
Absolutely.
Tuskegee. I mean, we could honestly go on and on, but we have to recognize that healthcare in this country is not equal, nor is it equitable. Two different things. Equality are two different things.
Right.
But neither is applicable to the African American. Right. You're a GYN, Dr. Crable. You know that the maternal fetal mortality rate is higher in Black women without regard to our socioeconomic status. So pretend like I was 15 years younger and I was having a baby, right? So the odds of something bad happening to me is much higher, even as a physician, because healthcare is not equitable or equal in this country.
It's not. Let me stop y'all. So we've got to pay some bills. That's what they're telling us.
Yes.
So we need to go for a few minutes and we'll come back. Hold on to that. That's going to be good.
great
So y'all read it.
I don't remember how it started.
Go to that.
Our back and forth. It always came back. Dad! You probably don't remember what you told me,
That was perfect.
but I heard every word.
Hey everybody, welcome back to Black Medical Journal. I'm Dr. Tamika Perry, and we were on a hot topic: maternal fetal mortality and morbidity. All those big words to me. Why does something bad happen to me when I have a baby because I'm Black?
That's a great conversation, a great thing to talk about, and it's big right now, right? It's out there. I have my own personal experience being a Black physician and what I have to deal with as far as educating my patients. One thing that I see, Dr. Perry, is that a lot of women want to advocate for themselves, which I think is amazing. And I do think it's twofold. I think that they are ignored. I think our pain is ignored. I think our bleeding is ignored.
Absolutely.
But as a doctor who doesn't ignore that, one thing that I do see is that when I do recommend something to a patient, sometimes I will get pushback. And that's where we have to really toe the line and understand, one, what is it doing when we do get pushback? It's okay to advocate for ourselves and to want the best. But if I'm telling you that your blood pressure is high and you're telling me that you don't want to do anything about it, then that's a problem also.
And I think that also goes to, having a good, open doctor-patient relationship. One of the things when Dr. Waggoner mentored me was having that good, fluid conversation between the doctor and the patient. you should, as a patient, you should be able to ask your doctor anything comfortably, and that doctor should be able to explain it to you on your terms what's going on. How dare I go to my fancy car place when I get my fancy car service and they tell me I can't ask a question? At the end of the day, we all have customer service jobs, right?
Of course.
This is still a customer service job. So it's not that the patient's so lucky that they come to us. I am blessed that you come to me.
Of course.
Patronize me, right?
Exactly.
So it's still a customer service job. So I need to be able to explain to you in a manner that is conducive to you that I am providing you with what's called a standard of care. If we don't lower this baby's blood pressure, it can result in liver failure, seizures, death for you and the baby. And this is how. And these are the pros and the cons of the medicines. And this is what we need to do. And none of us have any skin in the game. And it's really no physician, I say that with some caveats, have any skin in the game when it comes to like medicines, right? The medicine people don't pay our bills. Like, we're not trying to shove medicines on you. We're trying to give you a standard of care. And what happens all too often in all of our professions is that we don't get the standard of care. And then we have these adverse outcomes. And then we think that the care that we got caused the adverse outcomes. It was the lack of care that you got. Let me reference back to Tuskegee. So Tuskegee was like, well, they was giving people syphilis and stuff. That's not how that went. They found African-American men who had already had syphilis. Some of them
didn't treat it.
Then they didn't. They withheld treatment.
Yes.
See, history is very important. So we have to know where we're at so we know where we're going. Where we were so we know where we're going. Right. So they withheld treatment. So when you find a physician that has your best interest in mind, interest in mind, you should have a comfortable conversation. You should be comfortable enough to say, something going on with my kitchen, right?
Yeah.
And that physician understands that.
Right. I think there was something that you said about advocacy.
Yes.
So I think we ought to kind of drill down on that a little bit. So I think sometimes it's misunderstood what advocacy means. People think that advocating for myself means that I go in and I challenge the physician.
Right. That's the exact.
And so then that's how the relationship gets to be a bad relationship. Advocating for yourself should mean that you ask questions and you get them answered because you want to be part of your healthcare team as well. And so I think when we educate patients on how to ask the questions, and even when you say to the physician, I'm not challenging you in any way, I just need to fully understand so that I can make the best decision for myself. And then on the side of physicians, not to take it as though we are being challenged, but that they just want to know because this is their body. So I think when we get that straight, and advocacy doesn't mean that you in there, fighting for your rights for the people. That's not what we're talking about. Although you are fighting for your rights, but that's real important, and it changes the dynamics. And then if you go in with the right dynamics, and you have the right, listen, I'm just trying to, and if that does not work and you don't get your questions answered, then you choose another physician.
I really feel like that if a patient leaves my office with that deer in the headlight look, like, I have failed.
Right.
So I feel like I have failed. So I want the patient to understand, like, I understand. I draw pictures. I pull out stuff from the internet. And I say that, loosely because, Dr. Google is not our friend, right? And that's because Dr. Google at times will steer people in the wrong direction, but it at least allows that patient to formulate a question.
That's
what it does. It allows them to formulate a question. I say, okay, well, let's reel it back in and look at it from this perspective. And this is why I am doing X, Y, and Z.
Right. And it helps educate them. But I think that also what patients should understand that often what they are getting online is worst case scenario. So the best case scenario doesn't come to the top of what you get. And so if they understand that that's worst case scenario, but at least you understand the language.
Yes. Yeah.
So when we're having the dialogue.
And one thing I try to explain is that, people who are unhappy will put things online. Most of the people who are happy, they're not posting or putting things online. And so most of the time, it's like the news, right? The news is going to report all the bad things.
Going to lead with the bad stuff.
And so that's one thing that I make sure to educate my patient about. But I think the point that I was getting to also was that you made a great point of like, what is advocacy? But I also tell them that, yes, it's great to have these wants and these things in your mind that you you want. Like, I want soft music playing when I deliver. I want the lights that. That's fine. That's not advocacy. Advocacy is when you have that high blood pressure and the doctor doesn't treat you. Right. And then you turn around and say, hey, wait, I had someone, or I read that with high blood pressure, I should be receiving this kind of care. Right. That's advocacy. I think sometimes the problem, even if I explain everything to the T and exactly what you said, I'm telling them the reason why, and that thing, they could be harmed, their baby could be harmed, but they still have these thoughts in their mind of what they thought it should be like. Right. And so they feel like they're advocating for themselves to have the experience that they want. Right. That's my point.
And sometimes, just from our perspective, sometimes patients come and they want us to co-sign what they already think.
Right.
Now, we're going to talk through it, but I can't necessarily co-sign or validate if you have a thought process that is not medically accurate or not in your best interest medically, right? So a lot of my patients say, you know, I want to drink vinegar for my blood pressure. Mm-hmm. And I'm not saying that it's necessarily not going to work, but it's not going to prevent a stroke or a heart attack.
Correct.
And you have to think about medicines in this sense. If things like vinegar really work to significantly bring down your blood pressure, then how do you know how to regulate it? Right. Mm-hmm. So then you would go to the store, drink some vinegar, and, you know, the opposite of high blood pressure is low blood pressure, right? And so these medicines, or what you're trying to do is bring down your pressure. And if vinegar really brought down your pressure, you could become hypotensive and pass out. So therefore, just by logic and reason, it doesn't to that degree. And I'm not trying to hide any natural secrets, you know, because a lot of times, so why don't y'all tell us that this will work? Because it doesn't. You know, I'm not trying to give you something that's going to adversely hurt you. I'm really trying to perform what's called a standard of care that's catered to you.
So I have a question for y'all. We talk about what patients do or don't. Is there anything in your practice that you have learned over the course of practice that you are doing now that you weren't doing before, that your patients have taught you to help you be a better doctor?
Oh, yes. There's so many things that I learn probably every day. Trying to think of something in particular, but
listening.
Yeah. And listening, advocating, listening to about what not to do. You know, I think that's important. So a lot of times I'll ask, you know, how was your experience at the other doctor's office, or, you know,
what made you leave? What was
exactly, so that I can understand. But for me personally, I practiced with my business partner, which to me, this is the most important thing in my life. And my business partner is God. Mm. And so I feel like he is always giving me wisdom, things that I should do and things that I shouldn't do. I want to come back to a specific thought. That's a great question, but I'm going to let Dr. Perry kind of.
You know, patients always tell us, you know, I know my body, and I have learned to listen to that in particular, because it's true. You have been with your body your entire life. I may know science, I may have 50 million degrees, but you know your body. So I'm going to listen to exactly what you have to say. I'm going to take all those symptoms that you give me in its totality. Yes. And then I'm going to take what I know, we're going to put those two things together. Yeah. And usually when we put those two things together, both of us come out with an outcome that we are both satisfied with, the patient and the provider. Yeah. So the thing that's most important to me, even when I go to clinicians or I go see another physician, never tell anybody I'm a physician unless they already know me, right? Right. Because I want to see if you're going to listen to me. I really want to see if you're going to listen to me as a Black woman. I want to see if you're going to listen to me as a patient. I know my body. You know your body. Y'all know your body. It's been with you in your entire life. And it's so important that that physician listen to what you have to say.
Yeah, it is. I think that's one of the things that I have learned is the art of listening. Mm-hmm. Yeah. And I think when I first started practicing, I was listening so that I could answer.
Yes. Yes.
But now I'm not listening so that I can answer. I'm listening so I can hear them.
Right.
So not just hear what they're saying, but hear what they aren't saying. So sometimes I end up saying to patients, what is the thing that you are most afraid of?
Mm.
And they'll tell, because in the back of their heads, their aunt so-and-so had this and they died.
Right.
And it doesn't even sound like a big deal to us. And so it's like, oh, no, you don't have to worry about that. But if they think they're dying, if you can order one test to make them sleep better and not worry about that. So I think I've learned how to listen in a different kind of way.
Absolutely.
It's real important.
Absolutely.
Yeah. So have either of you all, I know in healthcare, so one of the ways that I have learned about being a physician too is how I've been treated when I go into, and you were alluding to that when you said, you don't tell people that you're a doctor. See, I'm just the opposite. I need you to know, right? I can tell you why I need you to know. Now, I need you to treat me like you would any other patient, but depending on where it is, and particularly if I'm with one of my family members, I need you to know. Because if you got some nice, I need you to pull out your nice. If you got some extra health care, I need you to pull out all of the things that help my people. So one of the things, have either of you all had an experience or anything that helped you?
Yes, for sure. I recently had an experience, Dr. Jill, that was very traumatic for me. Up until probably a week ago, I had a hard time talking about it without breaking out and crying because it was pretty horrible. But let me just tell you, so I had been doing a training all day. This was about 4 weeks ago, and I was having some pain in my right upper quadrant, and I'm a pretty
abdomen, y'all.
Oh, yes, in my thumb,
I'm barely up here.
right in the right upper area of my belly, and I am pretty tough, so I was kind of bearing with it all day. And when I got home from my training, I was like, let me take a Tums or some kind of acid reducer. Felt a little better for about 10 minutes, but when I tell you the pain that hit me after about 10 minutes was something I never experienced in my life. And so I jumped up off the couch and I said, I have to go to the emergency room right now. The pain started to go up into my chest and I felt like I was having a heart attack. And so I get in the car, I beat my friend to the car. I'm calling people on the way. Like, hey, I'm having this severe chest pain, this pain in my upper abdomen. I am coming to the emergency room. I live about 5 minutes from the from the hospital where I was going, which is my own hospital that I work at. And I get there, I jump out the car before it stops moving. I walk through the door. I go up to the counter, gripping my chest. And I'm like, I'm sorry to do this. I'm Dr. Crable. I'm having severe chest pain and right abdomen pain. And they're like, ma'am, you got to get in line. And I'm like, ma'am, did you hear me? I'm in severe pain. I'm crying. I'm gripping my chest. You have to stand in that line. There's nothing we can do. There's a line of about 4 people. So my friend comes in who is also, she's a nurse at the hospital. And she's like, what are y'all doing? Did y'all hear her? She's Dr. Crable. She needs to go back now. If she would have come in an ambulance saying she had chest pain, you would have taken her to the back. And I'm like, they're saying, so they keep saying, y'all got to get in the line. You got to get in the line. So I'm writhing around. I'm holding my chest. And a security guard comes up with a wheelchair. Is like, sit down, ma'am. So I sit in the chair, but I can't. So I stand back up. And he's like, well, if something happens to you, it's on you, not us. So my friend stands in the line for me.
Oh, my goodness.
Hold on. It gets worse. And so my friend stands in the line. She gives them my health insurance card and my ID card. And finally, I'm almost screaming at this point. I'm in so much pain. Okay, I can't explain to y'all. I'm a very tough lady, and I would tell you how you're gonna know I'm tough. But so they get me to a triage room, which is like still in the front of the ER, and I sit in the chair. They get my vitals, and I'm begging, I'm pleading with them, like I'm in so much pain. I need to get to the back. They're like, we don't have a room available. And I'm like, call everybody, have the doctor come see me how severe I am right now. They're still taking their time answering questions. I'm like, I need pain medicine. I'm in that much pain. I'm starting to sweat profusely. And the young lady looks at me and says, Mel, we don't have pain medicine to give you. So at this point, I get on the floor, okay, because that's how much pain I'm in. I'm feeling like I'm going to pass out. My vision is going black. I'm sweating profusely. I'm rolling on the floor, screaming at the top of my lungs for God to help me. Please don't let me die, God. like I'm about to cry right now. This is how real this is and how traumatic it is for me. So I'm pleading on the floor. God, please help me.
Who we need to roll up on?
Girl, are you locked in red?
I'm screaming though.
Oh my!
If y'all know me, like a lot of people know me, Pam knows me, I don't scream. I'm a very calm person. I don't even cry. But this is how much PTSD I have behind this situation. I'm rolling around on the floor. Finally, the house supervisor comes and she knows me. But before she comes, actually, let me tell you this, what the young lady said to me. A young lady that didn't look like me. She's probably half my age. She comes to the door and she says, "Ma'am, I understand you're in pain, but you need to get up off the floor." When I tell you, that triggered me, but I mean, there's nothing I could do, right? Because I'm in that much pain. Finally, the house supervisor comes and she brings the doctor with her and he sees how much pain I'm in and he takes it very seriously. He's like, "Oh my God, you could be having an aortic dissection. You could be having a heart attack. We need to get you back now straight." So once he came, it went very fast from there. It went very quickly, very smoothly. They got me to CT right away, found out that my gallbladder was about to rupture, and I went for emergency gallbladder surgery the next day. So it was just the gallbladder, but still, if it had been my heart, I think
You would have been.
I wouldn't be here right now,
Yeah.
you know? And just to think,
Yeah.
one, I told them that I feel like I lost my dignity on that ER floor. The fact that I had to lay there and scream for someone to help me, that's very traumatic for me. But to imagine that, you know, I am a physician that works here. A lot of people know me because of what I do as far as the robotic surgery. Obviously, those people didn't know who I was, but the fact that I went through that in the position that I'm in, then me imagining what my patients would go through.
I'd have to.
This was an institution you make a lot of money for.
An institution that I make a whole lot of money for. I mean, I am one of the busiest elective surgeons at the hospital.
So that you know, at the end of the day, we're still Black women. At the end of the day, regardless of our degrees, where we live, yes, we're real.
Yeah, I'm sorry. And I hate to get emotional, but it's still triggering me. And it's only been 4 weeks. So it's not been that long. And I want you to get your point across, but I want you to understand, after my gallbladder surgery, I was back at work the next day. That's how tough I am. So you can imagine if I'm rolling around on the floor, I'm in severe pain. This is not drama. I hate going to the emergency room. I will stay home as long as I can.
I get that.
You know, so I wanted it to be understood, like, I'm not just
Coming
rolling
on here,
floor.
I don't have nothing to do.
So
That part.
I work here
That part.
and we don't even like going to the ER specifically.
at all.
I really don't.
So part of what our whole conversation is about is because we understand, not only as Black women physicians, what it means to be on that side, but we've also been patients.
Yes, ma'am.
And that's unimaginable. You could take your dog to the vet and get better treatment.
Exactly.
And that is unimaginable. We have to do something.
But you know why that happens is because this is taught in school, in the schools that we went to. Up until even 5 or 6 years ago, it was taught in medical school that the pain threshold for African Americans was much higher than the general population.
Yeah, I was looking at some data not very long ago where they surveyed, it was a survey of medical students, and they asked the question, do African American women have a higher pain threshold? And the answer was yes.
So you're less likely to be treated for your pain. Your pain is less likely to be taken seriously.
Yes.
You're less likely to be given higher acuity medicines because, heaven forbid, you're probably doing something right you're not supposed to be doing those medicines.
Right.
You know, you're less likely to be treated as a patient with dignity or as a human being simply because you're Black. At the end of the day, I
felt that firsthand.
I'm a die Black.
Yeah.
The country has got to treat me better. You know, only 3% of the physicians look like us.
Right.
But we're 12% of the population.
Yeah. Yeah.
Why is that? Now, if you sit here and say that medicine is not political, you are sadly mistaken.
Yeah.
You know, we all need to put on our big girl panties and say, we got to vote. we got to advocate for us.
Yeah,
We got to vote
Yes.
for congressmen and senators who are going to advocate for STEM programs for children of color. They're going to advocate that medical schools let more of us in on merit, not just simply because we're a person of color.
Yeah. I think it's too real important from a historical perspective that we understand how we got here with these low numbers. How did we get here where we think that Black women don't have the same kind of pain? And the reason that's important is because even if you're a Black physician and you're unaware of your bias, you may be biased because of where you were trained. Exactly. So you don't even understand that even though they look like me, the patient looks like me. It was ingrained.
Yeah.
The training is ingrained.
I can give you an example. I can give you a great example, Dr. Waggoner. So, and I have trained at fabulous establishments, equitable establishments. But it was a particular course that I was in, and the professor talked about the rates of STDs, particularly gonorrhea and chlamydia, in the Caucasian population versus the African American and Hispanic population. And we had much higher rates of these STDs between 15 and 24. And this data was from the CDC. Reputable, right? And then he said, the reason for this is for the sex for drugs industry. So I instantly looked around at my colleagues and said, what did he just say?
Yeah.
And so afterwards, I went and asked him, I said,
say that out loud.
Right. Not allowed. And of course, in this, class of budding students, it was 250 of us and 8 of us were African American. But we all received the same information and nobody questioned it besides me. And in fact, when I asked my other colleagues who tanned as well as I do, hey, what y'all think about that? They said, shh, no cause trouble.
Right.
Because we're happy to be here. No cause trouble, right? So when I went and asked him afterwards, I said, sir, how did you come to this conclusion? He had read an article, and this is not made up, Time Life magazine, about increasing STDs because of sex for drugs industry. Didn't implicate anything about race, didn't say anything. Then he took the article from the CDC. He took the paper from the CDC.
And he superimposed.
Puts them together.
Yeah.
Now, what's in the head of all 250 young budding physicians? That if I were to come into the ER as a young girl with a belly like you had, so not only do I have an STD, but I trade sex for money? Because that's the thought process that you put in your head. And that's how bias starts. That's exactly how bias starts. Yeah. And it doesn't matter. The person, if you have a brain, you have a bias. So just because your doctor looks like you doesn't necessarily mean they don't have a bias. Because that's how it's ingrained in this country.
Absolutely. Okay, y'all, we got to make a living again.
Yeah. It's a great topic, and we'll come back after these messages.
I don't remember how it started.
Go to that.
Our back and forth. It always came back.
Dad!
You probably don't remember what you told me,
That was perfect.
but I heard every word.
Welcome back to Black Medical Journal. We have had an amazing conversation, so we're going to have to wrap this up, but we're going to come back, aren't we, ladies? Yeah, this has been absolutely great. So is there anything that you all would like to say before we leave?
I keep talking about, you've heard me use the words equality and equity, and I just want to make sure that, because this is so important for minority health, Black health, it's so important. Equal is if 2 people need transportation, one person may be appropriate for a car, but if you're 14 years old, you don't need a car, you need a bike. So we're providing transportation for both people, but we need to provide you transportation where you're at. That's the difference between equality and equity. So it's important that we provide equitable care as physicians to our patients. Meet them where they're at. Be grateful that they've come to patronize us, and be grateful that God put us in a position to service the needs of our community.
Yeah, I love that. And I guess my final thoughts are that, the whole advocacy thing and cultural competency. You know, we kind of touched on that a little bit. And just knowing that our pain is real, you know, as Black people, but as Black women in particular, that our pain is real. Just one short or quick example of that is I see a lot of women who come and tell me their periods have been debilitating, where they can't get out of bed. And they've told several physicians that they have this pain with their periods, and they've been told, oh, that's normal. It's just normal dysmenorrhea, which means painful periods. And they're telling me I have to miss days of work. I'm throwing up. I'm balled up. That's not normal. That's not normal. And so we have to go down the path or the differential diagnoses and give them the same care and attention and respect that we would give anybody else, and not think that they wouldn't have endometriosis because they are Black women. And so that's where I want to leave it today, in that, you know, I treat a lot of women with endometriosis. It's a very debilitating disease. A lot of women have severe pain, and just making sure that we take their pain seriously and we listen to them, because we talked about listening, we talked about advocating, we talked about taking people's pain seriously. And so that's kind of where I want to leave it on the physician side, not just the patient side.
Before we go, I want to say that I think that we have to take control of our health and our health care. And one of the things that I find often in patients is that they won't see the best doctor if their insurance won't come in.
Right.
So all of us are not people who can't afford healthcare choices.
Yes.
Make sure that your healthcare is a priority. Make sure your health is a priority. It's the only body you're ever going to.
Right.
And so if you don't care about it, who do you expect to? So thank y'all so much for joining us. And we look forward to seeing y'all again. Stay well, and we'll see you next time.